As we all know that these days, medical professionals are facing numerous litigations related to medical negligence. And we all must understand that ignorance of law can never be an excuse. And medico-legal awareness is extremely important, especially in these days when there are so many litigations. And as clinical evolution occurs, there is evolution of medical law also. So it evolves with time, and we need to understand and follow the medico-legal principles applicable to the practice of medicine. We must understand how medical negligence is assessed in courts, what is standard of care, what are we expected to do from legal point of view. So our first talk is medical negligence and standard of care, for especially for anesthesiologists. And for speaking on this topic, we have an expert, Dr. K.S. Sunitha. Madam is professor at ESIS Medical College, Rajnagar, Bangalore. And Madam has done LLB from Bangalore University with gold medal and has conducted many airway management workshops for postgraduates and practicing doctors. And Ma'am has also contributed 2 chapters in the textbook of Acute Severe Maternal Mortality Journal. And she has publications on ABGs also. Welcome, ma'am. Over to you, Dr. Sunitha.
Thank you, ma'am. So, shall I share my screen?
Yes,
Let me thank
please,
Indian College of Anaesthesiologists and ClearNet for this opportunity. I am extremely happy about this opportunity. Yeah. Yeah. Are my slides visible?
No, ma'am, not yet.
Visible now?
No, not yet, ma'am.
No.
No.
Okay. Now, ma'am?
No, not yet.
My God. Now?
No, I'm afraid no, ma'am.
When I tried, it happened, and now what's happening?
Yeah, no problem. Yes, ma'am.
Okay.
Yes, ma'am. Now we can see your slide.
Okay. I'm going to the... Yeah. Can you see?
Right, ma'am. Yes, ma'am. We can see.
Okay. Thank you. So this talk is supposed to be for 18 minutes. It may get prolonged to 22 to 24 minutes. So the medical negligence and standard of care. These are the 2 points which I am going to highlight. So we all know that medical negligence cases are enormously increasing in the consumer courts. Some of the surveys say about 24% increase in the medical negligence. This leads to a lot of litigations and forces us to do a defensive practice. So in order to avoid this, if we can follow the standard of care. What is the standard of care? Standard of care varies in each aspect of anesthesia, that is standard for documentation, standard for consent, standard for tertiary care, standard for referral care. But everywhere we have a standard, minimum standard that is meant for the safety of the patient. Once the safety of the patient is assured, the medical negligence naturally comes down. It is the aggrieved patient who goes to the court. So this topic I will be analyzing in the forum of medical negligence. Medical negligence has 3 components. One is the contract between the doctor and the patient. And the second is something is done which shouldn't have been done, or something is not done which should have been done. And that should have resulted in a damage. If the damage is not there, the court does not accept the case. All the three components are very essential to call it as medical negligence and the case to be accepted in various courts. So the standard of care, as I told you, it varies. One of the standard of care is clinical practice guidelines. These are the guidelines which tell us in any given situation how we have to deal. For example, the practice guidelines in a difficult airway and practice guidelines in massive transfusion and etc. Other standards varies, as I told you, in tertiary care, primary care, and type of anesthesia, oncosurgery, obstetric surgery. It varies with the standards. We have to follow the standard, and substandard care leads to litigations. The consequence of deviation from the standard is most probably adverse outcome, and adverse outcome is responsible for litigations. So, as anesthesiologist, our practice does not restrict to the operation theatre. It extends to ICU and non-operative room anesthesia, which includes acute chronic pain management, anesthesia for MRI, anesthesia for CT, cath lab, endoscopy, so on and so forth. The incidence of medical negligence related issues are more in non-operative related anesthesia because the maintenance of the standard of care is challenging in NORA. What happens in NORA is the importance is given to the endoscopist or cath lab, or experienced technicians are not available, anesthesia related equipments are not arranged properly. If you ask for a tube, they may give you a suction tube. They don't understand it as a endotracheal tube. So many things. So the standard of care is challenging in any area which is NORA. So how do we analyze that the substandard care has led to the litigations? The cases which have been decided in the court has to be analyzed, and the judgments given by them and the points put in the judgment needs to be analyzed. But we in India don't have any statistics or any projects like that. So I have taken American Society of Anaesthesiologists closed claim project. It was initiated as early as in 1980 to 85, and extensive analysis has been made of more than 10,000 claims. And they have analyzed the malpractice claims in which they have found recurring problems, which are the maximum number of problems which are responsible for the claims, and what are the causes for such problems, and analyzing this, what patient safety measures can be taken so that the claims are reduced and the patients are also happy. So the goal of the project remains as to improve the patient safety by changing the clinical practice guidelines and educate on risk management. In 10,000 claims that were analyzed, 30 to 40% of the claims were blamed on the substandard care, and these all belong to the American hospitals. And here I have put a table in which what is the substandard that has been proved in the some of the cases which have been the judgment has been given in the courts. So the first one is esophageal intubation. So esophageal intubation leading to the hypoxic brain injury bar death was common in the pre-capnography era. Lack of capnography leading to this problem becomes a negligent act, and the substandard care is lack of capnograph. And similarly, in a difficult airway, multiple attempts have been done without changing the technique. The same patient, same position, same laryngoscope has been used, which has led to hypoxia and brain injury. In that, the substandard is no change is adapted, and supraglottic airway devices has not been used to prevent hypoxia, and the anesthetists are not familiar with the surgical airway. So this demands that we practice all these things for the safety of the patient and to avoid the claims. In post-anesthesia care unit, all these are from the analysis of closed claims from the American Society of Anaesthesiologists. So in PACU, post-anesthesia care unit, excessive opioids leading to the respiratory failure, causing hypoxic brain damage or requiring the prolonged ventilatory support. So the vomiting due to MI and other cardiac events in the post-anesthesia room has been mistaken as post-operative vomiting and treated with the ondansetron or antiemetic, leading to the cardiac arrest later, and some of the patients have died. This is considered as lack of vigilance, lack of monitoring, lack of expert assistance in the PACU. So the hypotension leading to because of lack of monitoring of the blood loss, and which leads to shock dysrhythmias and cardiac arrest. So the lack of method to assess the blood loss and absence of expert anesthesiologist in the theater and lack of monitoring are being proposed as a substandard care. And regional anesthesia, total spinal, especially in the areas of non-operative anesthesia rooms in NORA, especially in the labor analgesia. Many of the centers, labor analgesia suite doesn't have a Boyle's apparatus, and total spinal is very common when epidural is tried and you are not getting the CSF when you withdraw, but when you inject the drug, it is going into the subarachnoid space. That also has resulted in the cardiac arrest. So the medication error that has been highlighted in closed claim is epinephrine having been used instead of ephedrine, and intrathecal tranexamic acid has been given, which has caused paraplegia, and epinephrine has caused death of the patients. So the poor labeling, lack of checking before the injection, and one anesthetist handing over to the another anesthetist, the taking over and handing over is not happening properly. Drugs loaded by another anesthetist is used by this anesthetist without cross-checking. All these things are the substandard care. The position-related nerve injuries, the multiple nerve injuries, improper padding due to lack of awareness and lack of proper equipment, which leads to neurological deficit. Because of that, patient claims in the courts. Obstetric anesthesia has a unique problems in that the regional anesthesia requires the lesser local anesthetic dose, which has not been analyzed, and usual dose has been given, leading to the high spinal and some of the maternal cardiac arrest. And also obstetric anesthesia with general anesthesia has lot of cases claiming the awareness and emotional distress. And awareness during anesthesia is not only related to the obstetric anesthesia. When TIVA is being used, without infusion pumps, so that optimum dosage is not going into the patient, and disconnection of the IV is not recognized. These are considered as substandard care, which has led to awareness and which has led to emotional distress. These are some of the things which are considered as substandard care related issues in 10,000 claims which were analyzed in the ASA closed claim. We don't have a Indian closed claim projects available, but still I have done extensive homework and put a list of cases which is considered as substandard in the Indian scenario, which I will be projecting in the later slide. So the patient safety concerns are the major thing to reduce the malpractice claims. That closed claim project which I am highlighting so far is funded by Anesthesia Quality Institute, a patient safety organization. And lessons learned from that project are identifying the injuries which led to the legal claims and their causes, and situational awareness and the errors. The communication failure and lack of communication, these three things I'll be highlighting in the later slides. Lack of communication regarding adverse events and near misses. We all know that when we manage a case fantastically, we put it as a case report in the journals. Similarly, when we have adverse events or near misses, it is never published. So the lack of publication is responsible for continuing concern about the repetition of such event with some other anesthesiologist. So majority of the claims are related to substandard care. So this is what I would like to highlight. The substandard care is responsible for as much as 25% of the claims. So the areas of deficiency that are found in standard of care, the situational awareness. And here I would like to present one simple case, a case of subcutaneous emphysema. We all know that if we give IPPV to a patient with subcutaneous emphysema, it is going to aggravate. But the senior anesthesiologist who enters, oh, hypoxia is happening, ventilate the patient with IPPV in the ICU. They are not aware of the situational awareness. That is what has caused the subcutaneous emphysema. So such lack of situational awareness can lead to real morbidity and mortality. So the communication error, this is a case of warfarin, which I will be highlighting in the coming slides. Workload management. This is especially true in case of odd hours, where a single anesthetist is available, 3 to 4 theaters are running, and the untoward event, unwanted thing can happen in 2 theaters, and one anesthetist cannot manage in 2 places. So it leads to adverse outcome. And decision making is very, very important. If you want to give the case, suppose the patient is on clopidogrel and has not taken, should I go ahead with the case or not? These decision making should be based on the clinical guidelines which are available to us, and the clinical guidelines which are available in India makes more sense than in the clinical guidelines by the other areas, because our guidelines would have taken the type of population we deal with and type of cases we deal with and type of genetics we deal with. So decision making should always be based on the clinical practice guidelines and in certain other conditions like NPO status. Don't take it as an NPO overnight. For infants, for children, it is very, very important. The NPO is monitored as intensely as intraoperative period. So lack of this monitoring has led to the children who have become very supple when they are brought to the theater. And the leadership and teamwork. Leadership should be such that when the leader says something, the whole team should feel that it is right and we have to follow. So of late, I saw in one of the anesthesiologist group, please don't cancel the case for lack of investigation. If there is a lack of investigation, take high risk consent and go ahead with the case. So this is this is one kind of not a leadership. It is not a right way of taking our specialty. Our specialty should be respected by us initially before we expect respect from the other specialties. So the most common complications encountered as per the ASA closed claim were 30% death and the 23% others, which others, it can be burns, emotional distress, airway injuries, permanent brain damage, and 21% of the claims are due to nerve damages. So the from 1970 to 1990, the brain death and hypoxic brain damage has reduced from around 60% to as low as 30%. The reason for this is the invention of N-tidal carbon dioxide and SpO2. But later if you watch, you see a little bit increase. What is the reason for this? The reason for this is of late we are taking more sicker patients and we are doing a lot of emergency surgeries and we are involving ourselves in the non-operating room anesthesia. All these things have increased little bit, but the introduction of SpO2 and EtCO2 has reduced the hypoxic damage events significantly. And see here 93 to 99, 93 events, and 2000 to 2015, 102 events. Each event means either it is hypoxic injury or death of the patient. So this is one example of substandard care. Here you are seeing a endoscopy suite where a 45-year-old 130 kg man is posted per ERCP. There is no anesthesia machine, no EtCO2, propofol, fentanyl, ketamine has been given. The propofol infusion also has been started. The patient is prone, he regurgitated, he became apneic, difficulty in rolling it to the supine position, and difficult ambu ventilation in view of 130 kgs, severe bradycardia leading to the cardiac arrest. Here the substandard care is the lack of equipment, for which we can't blame only anesthesiologist. Even the hospital management is responsible for it, and those who agreed to give anesthesia there also is responsible for it. And proning a prone position giving the sedation is something which is fatal always. It's very difficult to turn the patient, and by that time you would have lost your precious platinum minutes and leads to adverse outcomes. So this is what I said, communication failure. Here you can see the patient. The patient is 63-year-old ASA grade 3, posted for some surgery. He had hypertension, coronary artery disease, and atrial fibrillation. Because he had atrial fibrillation, he was on warfarin, which was stopped for 7 days pre-operatively. But on the day of the surgery, the anesthesiologist felt that some more investigations are required, and he cancelled the case. And he told to get those investigations and then repost the case. The patient was reposted after 19 days of stopping warfarin. Nobody asked him to resume warfarin and to be stopped 7 days before the further when he is posted for surgery. So the lack of warfarin, presence of atrial fibrillation, and when he was taken up for surgery, he landed up in severe thromboembolic event perioperatively, and he succumbed. So the communication failure can be content failure, which I told now. The warfarin was supposed to be resumed before the stopping for such a long period led to the thromboembolic phenomenon. Purpose of the, suppose we say purpose of the communication, like we say nil per oral status. But majority of the times, a pregnant patient coming for LSCS, the relatives feel that she won't be able to take proper food for another 2-3 months. Let her feed her nicely. This is very, very common. You should say the purpose of NPO is to avoid the mortality, which the food can enter into the lungs. That has to be given. If the purpose is not analyzed, it comes to the communication failure, which again comes to the consent only. So the audience, when any case is discussed, it is very important that the surgeon, anesthesiologist, as well as the nursing team is available over there. So how we are going to proceed with that. And a patient, for example, a patient is having porphyria, he should not be using thiopentone. The anesthesiologist says, I didn't hear to it and I used it. So these are the happens to the substandard care. And this especially happens when somebody else has done PAC and the person who is anesthetizing, without looking at the patient and the PAC, starts giving anesthesia. So this is the problem of audience. So the occasion. So the emergency situation is different from the elective situation, and the choice of anesthesia varies with the situation. All these things need to be analyzed to avoid communication failure, and the communication failure is also one of the substandard care. And substandard care related cases in Indian courts, and these are which I have collected from the various literature. And here we have in 2024, double lumen tube was introduced by a trainee and vocal cord palsy happened and 10 lakhs was the compensation which was awarded, and the substandard care highlighted in the court judgment was delegation of a critical task to the trainee. Of course, in the training hospitals, we have to delegate, but critical task to the trainee was one which was objected. Probably simulation-induced simulator training which should be done before they get into the actual patients, especially regarding critical tasks like double lumen intubation. In 2023 Mumbai, the excessive ketamine led to hypoxic brain injury. The improper pre-anesthetic care, inadequate monitoring, and overdosage were the highlighted substandard care in the judgment, and 12 lakhs was the compensation awarded. In Chennai, the anesthesia for MRI led to overdose and the patient could not be survived. So the overdose and poor monitoring were considered as substandard care, and 50 lakhs compensation was awarded. In Bengaluru, ASA grade 1 patient posted for implant removal died. The substandard care here was even more astonishing, that they said the death cannot be explained by the documents which are present in the case sheet. So the document has been inadequate and manipulated, and see 38 lakhs, so much of compensation was awarded. In Ahmedabad, C-section led to paralysis. I could not get the actual total details, but it is proved negligence and lack of post-anesthesia monitoring is what has been mentioned. But I am also really confused regarding what it was like. So these are some of the Indian scenario cases where substandard has been attributed for the negligence. So the other common problems which can lead to standard of care, which can lead to the problems are NPO status, especially in pediatric patients. Many of the times, the pediatric patients are kept NPO before shifting to the pre-op room. And after shifting to the pre-op room, many of the times IV fluids are not started. This also amounts to the substandard care. This is more severe in pediatric age group. It does apply to the adults also. And high-risk cases being started at late hours of the day. And when untoward event happens, the expert assistance is not available. Another anesthesiologist is not available. Extra technicians are not available, which leads to lot of adverse outcomes. Surgeons' preferences over patients' requirements. The surgeon says that I am arriving, I am just 50 meters away from the hospital, please anesthetize. Once you anesthetize, for some reason, if the surgeon does not land up, so you will land up in the problem. The law does not allow you to give anesthesia in the absence of surgeon. So this should never be a practice, though it is extensively practiced. So if the patient is a high-risk patient, surgeon wants to go somewhere, he wants to finish his case, which is a lower risk when compared to the high-risk patient. So that patient is put first, and later we get into high-risk patient started at 2 p.m. and 3 p.m. and getting into the problems. And many of the times, surgeons do not put the order of cases. This is the first case, this is the second case. The order is not put, and they will take whichever case they want, which will increase the NPO status and emotional stress on the patients. And they do not communicate the position of the patient. See, for example, if you have a shaft of humerus fracture, it is operated in the supine as well as in the semi-prone position. In semi-prone position, I cannot afford to give only block, because if the surgery extends and block wears off, I cannot turn the patient and give the GA. So it is very important the position of the patient is mentioned in the list, which does not happen majority of the times in majority of the institutions. And the other major problem which also leads to substandard care is posting more cases than they can operate to accommodate cancellations. So they post 6 cases when they very well know they can operate only 3 cases. And the patients who are cancelled would have been NPO and overnight and NPO after coming to the receiving room. Probably at 3 o'clock or 4 o'clock, they will tell them that your case is cancelled. This leads to emotional distress, and with the coming up population who are pampered people who are coming, they will not be liking these things and they can claim as a substandard care. And shifting the patient to the OT without confirming the investigation reports and telling that you please start the case by that time the investigations come. And if a potassium comes as 5.6 after starting the case, what one can do? So it is very, very important that all the investigations are available. And if it is not there, an anesthesiologist always have the right to refuse to start the case. He should not be pressurized by the team leader to start the case, which happens very often. Having one difficult airway card for multiple theatres is another common problem which we all face. And here I would like to highlight in the American Society of Anaesthesiologists closed claims, they have mentioned 2 cases of awake fiber optic intubation going into hypoxia. They have claimed that they have taken a very long period and lot of secretions which has clogged and they were not able to intubate. They went into a state of the cannot intubate, cannot ventilate hypoxia, and they lost 2 cases. This is in spite of the fact the awake patient with little sedation, they were doing the fiber optic intubation. So it is very important that each theatre has a difficult airway card. And unavailability of 2nd and 3rd generation supraglottic airway devices and sometimes even the simple supraglottic airway devices. I consider supraglottic airway device as a real savior when you get into hypoxia and you are in a situation you don't want to intubate the patient. It is very important that your difficult airway card contains the all generations of supraglottic airway devices. Non-availability also could say that it is a substandard care. So lack of maintenance of monitors and reuse of disposables, especially the ETCO2. ETCO2 tube is so small, it gets blocked with the secretions or the moisture that accumulates from the patient expired gases only. They are meant to be disposable, but each time they blow it and we are reuse it, and sometimes it malfunctions and you think that I have intubated, I am sure about it, and it is not, ETCO2 is not being shown because the tube is blocked. It may be other way around also. So maintenance of the equipment is very, very important. So with this emergency single anesthesiologist monitoring multiple theatres is a real problem in our specialty. They are pressurized to such an extent, sometimes 3-4 theatres are and legally we are not allowed to monitor 2-3 theatres, and legally clearly says one anesthesiologist is required for one patient who is anesthetized. This also should be avoided. All these things are not only from the anesthesiologist point of view, it also needs the consensus from the surgeons, surgical team, as well as from the management. These are some of the substandard care related issues which I wanted to highlight. So with this, I conclude the session, and also my concluding voice is that the substandard care happens in almost all the institutes. It is not only the anesthesiologist who is responsible for substandard care, it is the surgical team and management. So all of us should sit together and try to solve this problem to the extent possible. Thank you.
Thank you, Dr. Sunitha, for such a comprehensive talk. And I just want to stress on one thing, that in court of law, we are expected to exhibit reasonable standard of care.
Yes.
So in cases which are high risk, when we take up a high risk cases, so then in those cases, we are expected a higher standard of care should be maintained. And we all do that. And whenever we are taking up high-risk cases, we take high-risk consent, and it must be very nicely documented. And even for intraoperative management, when we are taking up a high-risk case, the documentation should be very nicely done. And especially in cases if there are any unanticipated problem that has happened in the OT or in the perioperative period, we must, after the case is done, we must sit down, spend some time nicely and document the case properly in the file, rather than spending time later on in courts and in medico-legal committees. We must sit down and document the case management properly in the file.
I will add one point here, madam.
Yes.
Whenever you witness an adverse event, you scrutinize that chart more and sit and write it properly. When the outcome is fine, there is no problem, it is fine. But when you have an incident which you call it as adverse, please sit and scrutinize the case sheet before the patient is discharged or before some other event happens. And the limitation period is around 2 years. That means from the onset of the event till 2 years, the patient can go to the court. But they will say that death has happened, the patient was sick, so we were not in a mental status to claim, and it gets extended up to 3 to 4 years also. So we have to be very cautious about these things.
Right. Yeah, they are very liberal for taking up cases. Even they, although it said for 2 years for consumer courts, but consumer court takes up cases even after 3 years, 4 years.
Yes.
And we must never deviate from the guidelines. Whatever guidelines are given, standard guidelines, they must be followed. And in case there is any reason for deviating from the guidelines, the reason must be mentioned in the file. And ideally, it should be only life-saving emergencies for which you may deviate. Otherwise, you must follow the guidelines. And documentation has.
I have one case. If the time permits, can I explain that?
This
please. Is a case in Indian scenario. Agrasena Hospital versus some baby. One baby which is born at 29 weeks and it weighs around 1.7 kgs. And from the obstetrician, it is shifted to the NICU. NICU, it was there for about a month. And then it was discharged. And 4 follow-ups happen before the mother notices that the child is not able to see. So then she comes back to the hospital and asks for the documents. They refuse to give the documents. She goes to IMA, take the permission of IMA and gets the documents and proves that the clinical guidelines clearly says that prematurity, it is very important you check the eyes for retrolental fibroplasia, which has not been checked at any point of time, including the 4 follow-ups, and that has led to the blindness of the child, and 75 lives were avoided by the court as a compensation.
Yes. Thank you, ma'am. So I think we'll take up a question at the end. And next talk is thank you, ma'am. Next talk is organ transplant. Okay, ma'am. Okay, Dr. Sunitha.
Thank you.
Our next topic for discussion talk is Organ Transplantation Act. As we know, a lot of centers have opened up recently, which are doing transplant surgeries. So it is very important for anesthesiologists to know this act, Organ Transplant Act. Not only those anesthesiologists who are in the transplant team, but also intensivists and also intensivists and people who are clinicians who are practicing end of life care, because this is the only act which has legally defined brain death. So for next talk, I would like to invite Dr. Vijay Vohra, sir. Sir is Chairman, Liver Transplant and GI Anesthesia and Intensive Care at Medanta, the Medicity, Gurugram. And Sir is Liver Transplant and anesthetist, and areas of interest are organ donation and transplantation, bariatric surgery. And sir is chairman, liver transplant and intensive care, Medanta. Sir is fellow, Indian College of Anaesthesiology, fellow Royal College of Anaesthesiology, and is member of NOTO. And sir has numerous publications, and some of them are outcome of living donor and liver transplant recipient with coronary artery stenting, fast tracking in liver transplant anesthesia, and hemodynamic monitoring in liver transplantation. Over to you, sir.
Thank you, Anjali. Thank you for the kind introduction. I had something to say for the last presentation. I thought I could contribute there, but I think we'll come back to that towards the end. Is that right?
Right, sir. Right, sir. Bill.
Okay. Okay, let's get on with this then. Understanding the Organ Transplantation Act, Medical Legal Guide for Anaesthesiologists. So, I'll just tell you how this act came about. Giving a bit of history will give you a little more insight what was happening and why it was brought out. Then, of course, we'll go through what the act is and take it from there. So I'll take you through a little bit about the history. This came in 1994. The aim was mainly to regulate removals and storage of organs in transplantation, both organs and human tissue. It was not just organs. So initially, when it started, when they made the act in 1994, they only named it as organs.
Sorry to interrupt you, sir. So
Yeah.
your screen is not. Sir, could you please share your screen, sir?
I did. I thought it was.
No,
No, sir. Sorry, it's not.
Sorry. I thought we were sharing. Okay. Oh, sorry. Yeah.
Yeah. Yes, sir.
Is it there now?
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
Okay. Are we there now?
Yes, sir.
Yes, sir.
Okay.
Understanding the organ transplant. Yeah.
Right. Okay. So anyway, the idea of this was to regulate removal, storage, and transportation, both organs and the human tissues. Let me just minimize this site. Oh, what have I done? Is this still there or not?
It's there, sir.
I've minimized. Just a minute.
The toolbar is there, but it's okay, sir.
But I got to see properly.
Okay.
मैंने उसको minimize उधर कर दिया, so that's probably gone from there. This is trying to act too smart. This is what has happened. I think this is okay. See, what was happening is your photographs were coming on the side, so I was trying to move that out.
Okay.
So, okay.
Okay.
Okay. So again, the aim for this Organ Transplant Act was, I said, regulation, removal, and storage of both organs and the tissues. So it's not just the organs, the tissues as well, like cornea, other tissues, and which could be used for both therapeutic purposes and also, don't forget the last line, prevention of commercial dealing. This was again one of the things why this came in. It was regulating, make sure that there's no commercial dealing, because that is what was going on. So having said that, we're talking this act coming into force in 1994. Before that also we had transplantation, kidney and KEM, which recorded first one is 1965. 66 again, there was another cadaver donor. These were both cadaver. Third one was also cadaver donor. So these are all recorded there in literature. So before the act also, this was going on. So both of it, live donor was totally unregulated. Rich patient, poor donors. I mean, again, this is always going on. Organ trade, middleman, donor safety. I think we in Sir Gangaram do know about it. You know, there was a lot of hue and cry during our organ transplant early days, when one of our transplant surgeon was also being incriminated, but then finally, of course, he he got to the right side of the law. Again, for deceased donor, there was no recognition of brain death. I do remember early days when patient would be on the ventilator. You know, this patient is not going to wake up, but there was nothing there to, nobody could say, let's do the brainstem death and, we can switch it off. So again, so there was a really need for that. And, these are a lot of photographs you must have seen. Assam, Calcutta, everywhere it was, these rackets were going on. Poor people getting money and, rich people getting the organs. So brainstem death was not recognized. So that was the reason of getting this death, which really what they're trying to say here is permanent disappearance of all evidence of life after birth has taken place. What they're trying to highlight is it also includes not just brain death, it could be also cardiac death also. Again, this second aspect is slowly coming into use, whereby we are also using donors after cardiac death, organ donation after cardiac death. So it's not picked up here so much, but it is picking up. So again, keeping that in mind, it's not only the donor after brain death, death after any evidence of life, whether it is brain death or cardiac death. So again, trade in human organs, especially kidney is the notorious one. This has really been exploited by the rich. Body part, generally the kidney. Middlemen, of course, they probably make more money than the donor also. So coming up to build up to THOTA, the Human Organ Transplantation Act, it took a long time. It's not that they were not thinking in 70s and all. They were all thinking about it. 89, the National Academy of Medical Sciences, Bioethics, they were given the charge. Then again, they met in Madras, Calcutta in 1990, Health Ministry, WHO, and, Dr. Singhvi was the person in charge to clarifying the concept of brain death at its definition, define it, clearly, which can be followed. Desirability of separating legislation for the purpose of legal purposes, safeguarding, prevent misuse of the concept, like anybody could not just declare, like any hospital could declare brain death. No. So a lot of things had to be taken care of. So Dr. Singhvi submitted his report in 1991, and 93 bill submitted to Rajya Sabha, 93 Lok Sabha. So again, it's gone through the whole process, referred to select committees. Again, select committee, what did they say? They say in-laws to be included as relatives, and they also wanted payment to the donors. Mind you, these were the recommendation of the select committee, but then these were really not accepted by the wider, when it was reconsidered. So these two things were taken off. Finally, 15th of June 1994, this bill was passed. President gave his assent, and first heart transplant in AIIMS, that happened after the law came into force. Having said that, that was also not right. That was not according to the law. Although it was passed, it had to be ratified in your own state, etc. Again, Parliament has allowed, but then health is a state subject. Although they did first heart transplant, again, that was legal, but not quite legal. It had not become a law as yet. So then, of course, they said some parts of it, authorization committees. There are authorization committees for authorizing these transplants. There is a state level committee. The chairperson is the chief medical officer, 2 other members, senior medical practitioner, but they should not be from the transplant team. They should have nothing to do with the transplant, donor, recipient, no way, not connected with that. Secretary Health or his nominatee or nominated person, 2 senior person, could be non-doctors, doctor, lawyer, anybody. But the whole thing must make up 4 people. So there have to be at least 4 people in this authorization committee. Chairperson is the chief medical officer. So what happens is when you have more transplant in your, let's say, hospital, and then this is, of course, this is Noto is the right on top, and then you have regional, then state, then again level at lower level. So you can have authorization committees at all levels. State levels, again, for everywhere is good. But if your hospital does more than 25 transplant, then you can ask for a committee in your own hospital. So you will have a committee based in your hospital. So that's again, it is all there in their protocols. So let's consider separately. One is a disease donor, one is a live donor. Let's look at what are some of the issues in disease donor. Disease means person whose life is really a permanent disappearance of life that has occurred, which could be, like I said earlier, it could be cardiac death or brainstem death. And who can be a donor? Anybody can be a donor who has given a consent for a disease donor. So that means you cannot remove an organ if you're not given consent. But if you're dead, so obviously, how do you give a consent? So for that, why they say 2 or more persons should be aware of it, authorized before the time of death is through a donor card. So you must either be registered in a donor registry, and best is if you really are keen to be a donor, we are again right now, remember we're talking about disease donor. So if you want to donate, if you want to be an organ donor, best is register, carry a donor card, and let your family know. Otherwise, there's going to be a problem later on. So what is this called? This is called opt-in. That means you say, I have no objection by giving in writing. So you have given in writing that you want to be an organ donor. So this is what is called opt-in. We'll talk about opt-out later on. Opt-in means you have to give a consent. So nobody can take organs from you without your written consent, which you have given as a form, in the form of saying that I'm going to be an organ donor. I think we got this repeated here. Why is it coming in? Okay, consent for donation. Let's say somebody had not given this, doesn't have a card. What happens? So the person who is in lawful possession, so whosoever is close relative, he can be the one, can be called as person in lawful possession. Because you died, person is died, next of kin, whosoever is there, that is the person in lawful. Now that person, again, unless he has a reason to believe that he has an objection, he says, look, brain dead, lying in the hospital, he's in this thing, but if he believes he would have had, or his relatives would have had any objection. So what we are trying to get at is, there has to be an effort made to find out. It's not that somebody dead lying there, I'm in possession of the body, I mean next to them, and you get signatures from me and take the organ. You have to make sure effort has been made to contact his next of kins, and they don't have any objections. Unclaimed body, again, near relative, you must make any attempt to get hold of next of kin. And after, if you have not been able to contact them, you have to wait for 48 hours. It's only 48 hours have passed, only then you can think of taking organs from that person. Post-mortem examination, I think this can be worked out in the sense if it does need a post-mortem, the law is very good that way. If you are retrieving an organ, generally the CMO manages to convince the person who is supposed to be doing autopsy to come to the operation theater, retrieval is being done. So basically they want to make sure that nothing is missed out. There might be some foul play because post-mortem is done to rule out cause of death when you're not so sure. So generally those post-mortem people can come in when the donor retrieval process is going on in a medical legal case. Again, these are various forms which has to be signed. Brainstem death certification, of course, it has to be done twice, at least 6 hours apart. You do it once and you do it twice, a second time after at least 6 hours. Minimum has to be 6 hours. It could be longer. And there have to be 4 people. One is the medical administrator of the hospital. Of course, he won't be doing the test, but he has to be a signatory to it. That means he is authenticating what has been being done. Authorized specialists, whosoever there in the ICU, neurologist, neurosurgeon, medical officer under whom the patient is admitted. So these 4 guys must sign, and in fact, the testing, ideally, the testing should be done in their presence. Now, again, there has been a little bit of change. If neurosurgeon and neurologist is not there, he can be replaced by a physician, anesthetist, or intensivist. So that's what is coming in the few more modification which has come in 2011. So much for deceased donor. Let's look at living donors. Again, living donor, you still have the same sort of committee which is there, which looks at all the donor documents and the recipient documents. And relatives, near relatives, of course, can donate. No problem about that. Spouse, son, daughter, father, mother, brother, sister, these are the near relatives who can give. But like I said, again, there has been a change. So, all these changes are going to keep on occurring. As the time goes, you are more aware, the problems come, and you try to find the right solution. So then, now what they have added is, they realized over the period, they had discussed in various forums. So THOTA 2014, with the new document which has come, which is mainly incorporating the suggestion given in 2011, and where they have near relatives also includes grandparents and grandchildren. But still, I don't have a near relative. What do we do? Unrelated. I mean, we're not talking of, money being given. Unrelated also can be donors. So you have to make sure there is no commercial transaction. This is the job of the authorization committee. They try to establish connection. I mean, where did these 2 guys, donor recipient, you can't just pick them off the road. They'll try to say, show us their photograph, blah, blah, all those things. Reason why is he donating? You have to say, look, I know him, blah, whatever. The committee has to look at that. Documentary evidence of connection. Were they studying in school together or something like that? They look at all that. old images, photographs, and they have to make sure no middleman in between. And they also look at financial, very poor man being the donor, very rich, you're going to have very, very huge difficulty for them to be becoming donor recipient. So they look at all that. And of course, make sure donor is not drug addict. Sometimes, drug addicts come forward for donation. Ensure, and also they try and say, okay, look, who are your relatives? Why are they not donating? They look at that as well. So again, they take a lot of precautions, unrelated. They do it like, say, sister-in-law or whatever, not a near relative. But then nobody in the family, you are O group. You don't have any O group in the near relative. So again, those are possible through the authorization committee, and these are the form donor recipient. They all sign all that, form 18, 19, and there are various forms. In fact, there are 21 forms over there. Not all of them are required for all things, but there are different forms. Won't go into that. So again, just highlighting some of the amendments which were done to 1994. I did talk about some of them, but then let's just have a look at it. The tissues were not initially included, so that they have included. Near relative, we already said, grandparent, grandchildren. Another thing that they talked about is retrieval center. Not transplant center, retrieval center. So they also brought in where, let's say, some place where somebody is brain dead, but they're not a transplant center. But then organs can be retrieved. And I'll just talk about that later on, how they decide on retrieval center. So you can have only retrieval center and not a transplant center. That's possible. And then they also included swap donation. In the sense, I have a recipient, I have a donor, but we're not matching. There is another one, donor, recipient, not matching. A, B, B, A. So they can do a swap. So that earlier was not included, but then under 2011 amendment, they included that. Provision for mandatory inquiry from attendants admitted in ICU, informing them about the option and the consent. Again, basically, they have to find out from all their relatives about donation, and also provision of coordinator in all hospitals under the Act. So you cannot have transplant center without any coordinator. Brainstem certification board, again, you have to constitute. You have to send a transplant center has to send a list of doctors who can do the brainstem death criteria. So, as a transplant center, you might forget that, you are doing the testing, but you must keep updating. Sometimes the centers do forget. So you have to send the list of doctors to NOTO. Look, these are the people. I mean, look, somebody coming in fresh, ICU, you can't let him do the brain death certification. So he must go through the process. First, within the ICU, get certified, and then you send this name off to NOTO as a person who could do. So you have to send those names off to NOTO. Advisory committee, enucleation. Another thing, enucleation of cornea has been permitted by trained technician. So initially it was not there in the Act, now it is there. I think that's the main. There will a lot more nitty-gritty. So about the retrieval centers, which can be a retrieval center, all hospital having intensive care, adequate facility, manpower, infrastructure, equipment. Again, you have to all that. They should be able to diagnose as well as maintain the brainstem and that person. They should have facility for, that means OT, etc., for retrieval. They should have, the stuff for transporting those what you call boxes, facility for temporary storage, and they should be registered. So there has to be a registration for retrieval center. You can't just say, some nursing home in the corner, they have a brain dead person and you can go and retrieve there. That's not possible. So for retrieval centers also have to be registered. This is another thing, donor advocate. That's also coming new. Each transplant center has to have a donor advocate. So generally most hospitals which I know of, they keep the medical superintendent as the medical donor advocate. He's an independent representative for living donor. Give him all the information, ensures the consent is proper, he understands, educate about his risks, etc., decision making. So basically that's the person behind him. So that is one person the donor can go to, and obviously not related to donor recipient teams. This has got, he should not be from donor team, he should not be from the recipient team. Like I say, most places keep the medical superintendent as such, but some person who's not in the donor or recipient team can be a donor. Okay, I think that's about it. But what is the way forward? First, we had 1994, THOA, then THOTA, 2011. But I'm sure there is need to do more things. I'll just quickly, a couple of more slides. Opt-in versus opt-out. Remember we said opt-in, you have to give it in writing. Another suggestion is to have a way of opt-out, in the sense everybody is brain dead is a donor unless he says, I don't want to be a donor. So opt-out means you are a donor, full stop, unless we are given in writing, compared to opt-in, whereas you have to give in writing, I want to be a donor. So opt-out means you are a donor unless specified. I think it's the same thing. Opt-in requires expression to donate, opt-out automatically pursue. So that's it. So maybe that's one way to look at it. Maybe one should look at it. Spain does it this way. They have opt-out. Everybody they've had a lot of discussion. They have opt-out policy. In India, we are still opt-in. Maybe something to suggest, talk about it. There should be more awareness, and maybe that will be one way of increasing the donor pool. But then again, it's not so simple. Iranian model. In Iran, there is a legal structure, whereas donor is paid. So, but that's under all the government umbrella. Something is paid by the recipient, and the government tops it up. So again, I won't go into all these details. That's another way. I don't know. In India, probably this will not work. They'll be dealing and trading in organs. So these are various studies, various studies, various people have looked at it. Some of them, China, for instance, first study, they looked at it. They said, yes, we should think of financial compensation. Various, even in one study from US, where they have looked at 1,011 respondents, 59% were willing to pay $50,000 to get a donor. So what I'm saying is, these are something to think about. What is your social structure, and think what is the way forward, how to increase the donor pool. There are a lot of people wanting this thing. And this is, last one is something for anybody to comment on. These are 3 zones of organ donation area. Anybody can tell me what are these? I'll clap for that. Thank you. That's it, Anjali.
Thank you, sir. Thank you for such an insightful talk, sir. Very comprehensive. Just one
Can you guess what it is? Come on, you only guess. Can you guess these different areas?
Organ donation, sir. Green is green, yellow, and red, na, sir?
Yeah, there are only three. Yeah.
Yellow means very less organs available for transplant.
Or kuch,
Or,
or kuch.
live organ donation. We are doing more of living
Dr.
organ
Sunitha?
donation.
Dr. Sunitha, any guess?
G-
भाई yellow तो साफ नजर आ रहा है is India.
Is India.
Yeah. So whatever is happening in India, that's okay. And rest is red except a little bit of green. So that
Green is.
yeah, guess green. अगर green बता दोगे तो तुम्हारे full marks.
Okay.
Anyway, just green is Iran. Iran is the one
Iran.
where
Okay,
they-
disease organ because they have opt out.
yeah. No.
Yeah.
Iran is where there is paid donation.
Paid
you
donation,
pay and
paid
you can
donation.
get the organ.
Okay, opt
Rest
out
of
is
the
basically in Wales and Spain. Yeah, okay.
Yeah. So,
Wales.
anyway.
So
that's
one thing for donor,
Mm.
consent of the donor for donation, organ donation, do we need video consent? That consent is recorded, audio video recording is done?
Noto doesn't say that, but everybody is doing it.
Doing
It's to make
Yeah,
sure
I
you have. you
think
have
it is
that.
indicated, Hansi.
Yeah, I mean, that's okay. Makes sense in the sense
Mhm.
you have a proof. So even the authorization committee is worried. They also don't want to be implicated.
Especially non-related donors when it is done just for altruistic basis. So I think it is recommended that it should be video recorded. There are only few areas where video recording of consent is advised legally. And so one thing, Anju,
Yeah. Yes, carry on.
what if there is a minor, less than 18 years or 17 years, brain dead, and for organ donation? So we need consent of both the parents. Can the organs be used for transplantation?
Yes, of course. I mean, you'll be.
A minor brain dead.
There's no stoppage on that, that age-wise. Only in fact, one
And
parent
we need
is
consent of
enough.
both the parents or only one parent? Sir?
I think at least the law, what you call Noto says parent, a parent. I mean, again, you see, the thing is, as I said in one of the slides, attempt has to be made to get hold of the near relatives. So even if the parent is not there, I mean, let's say they should try and get hold of the parents and get it. But yes, pediatric is no issues. They can be. We recently did about 6-month-old baby whose organs were donated. That's not.
Yeah, and one more thing, sir. What if donor or recipient, one of the person is non-resident India, but yes, related, but non-resident India, non-resident of India at present?
Yeah.
Can that person donate?
Yes, that is, you see, non-resident is a different thing altogether.
Person who's related to recipient, recipient is in India, and the donor is related to recipient but is not residing in India, has gone out abroad and is now NRI.
That is not a problem. So
That
far
is
as
allowed.
the relationship is established.
Yes.
Even the foreign nationals can give to foreign nationals. That's okay.
Okay. They can come here and get the transplant done.
Get the transplant done. Get the clearance from their embassy. That's embassy is the paper is the sacrosanct. But like you say, if they are living outside, it's not an issue. This will have to be done by the state level committee. Not a problem. Yeah.
Okay. So one more thing. Have you started in your institute circulatory death transplant? Lot of institutes have now started, especially kidney, and they've made guidelines also, sir.
Yeah.
I think
that is a way forward. That will happen. I think what we did one, tell you the truth, we
Okay.
did just one. We did,
Mhm.
as you know, we do mainly livers. So
Yes.
livers is different. Again, liver, what? Liver, kidney. Kidney also, they have to be taken out from somebody who is dead.
Yes.
I think where we will do very well is once we start doing machine perfusion. You know,
Yes.
machine perfusion comes in, we have, that will be a way forward. You take out the organ after cardiac death and put them on machine. You see it's performing the function. You know it is
Yes.
usable in the next patient. Again, I'll tell you the patient which we did donation after cardiac death. This patient was going anyway. So vascular patient, and they had agreed. The family has agreed to donation. Heart was still going, and then we moved the patient into the OT.
Okay. Yeah.
And we waited for the heart to stop, then everything started off. So it is in a controlled cardiac death is probably something which is probably much better. And also, like I say, if you have machine perfusion, you put those whether it
Right.
is kidney or the liver, put it on machine, see that it's functioning. Kidney, if it is producing urine, etc. And you can, it's going to work. Liver, again, it starts producing bile. You see the content of the bile. If it is improving, it is doing the function and all that. So yes, that is again one thing which will come up soon.
Right. So such a long waiting list and NOTO and a lot of patient waiting for transplant. I
Yeah.
think this is how we can increase organ pool.
Yeah.
And especially if we start practicing end of life and patient gives advanced consent, advanced directive, we can take up the patient in OT as soon as circulatory death
Yes.
occurs and organ transplantation can be done.
Yeah.
So,
Yeah.
okay, thank you, sir.
Thank you.
I think we'll take up questions from delegates in the end, sir.
Yeah.
And
Shall I stop sharing now?
yes, sir. Yes, sir. Thank you, sir. So our for the next talk, I would like to invite Dr. Anju, ma'am, Dr. Anju Bhalotra. Madam is director. Ma'am, could you please share your screen, ma'am? Yeah, thank you, ma'am. Dr. Anju is director, anesthesiologist, Maulana Azad Medical College. Ma'am has main interest in pediatric anesthesia and airway management. And ma'am has many publications. She is a gold medalist and first rank in MD Anaesthesiology from AIMS. Ma'am is AHA certified ACLS trainer and has several publications in international and national journals. And she's on review boards of several journals and member specialist board for anesthesiologists at NB board. So the topic for the talk is perioperative death and its implications, medico-legal implications. Anesthesia, although is very safe, but it's a very high-risk specialty. And this dreaded complication, intraoperative mortality, is a real nightmare. So ma'am is going to talk about the medico-legal implications for anesthesiologist. Over to you, ma'am, Dr. Anju, ma'am. Ma'am, you are muted. Could you please unmute? Dr. Anju, could you please?
I'm there. So I'm sorry. So thank you for the introduction, Dr. Anjali. My topic today is intraoperative mortality. And as you said, that is a very shocking event that happens for most of us as anesthesiologists. Intraoperative death is something that we don't really want to face, but unfortunately we will all, when we are working, we will all face this sometime in our lives, and we must know how to handle it. Yeah, so intraoperative mortality or death on the OT table. Now, there are various definitions in the literature regarding these deaths. An operative death has been defined as a death that occurs within 30 days of the surgery. And in this case, the cause of death is thought to be directly or indirectly due to the surgery. An anesthetic death has been defined as one that occurs within 24 hours of the administration of anesthesia, and it may be due to causes related to anesthesia. However, there is no ambiguity about the definition of death on the operating table or a death or DOT, and a death on the operating table is merely a death happening during a surgical procedure. It is a very rare and serious condition, and it has very grave medical, legal, and social consequences for everybody who is concerned with this event. Now, when a DOT occurs or a death on the table occurs, there are two extremes of situations in which it may occur. In one situation, the patient might have already been a very high-risk patient. And in this patient, maybe the death on the table was a significant probability or a possibility. And in this case, the family members will have been prepared for this bad outcome. So obviously, since they are mentally prepared and they know what has been going on, the repercussions are likely to be much less. And in this case, only grief counseling for the family will be required, and this will not usually lead to much of an impact on everybody. On the other end of the spectrum is a totally unexpected death, which is obviously more horrific. It may instigate a lot of violence. It may have very violent reactions from everybody concerned, and it will have great repercussions in all respects and a lot of trauma, mental, social, professional, to the operating team, the relatives, and the medical legal consequences may be profound in these cases. In between these two extremes, there are a variety of causes which you may have a high-risk patient, but who's not likely to die on the table, but they may. So you have a whole spectrum of causes in between, and the response to that will be depending upon how unexpected that death is. So there are a whole lot of reasons for intraoperative death. There could be patient-related factors where the patient has got severe underlying comorbidities. He's a very old man, advanced age, he's very frail. There could be a severe polytrauma with ongoing hemorrhage and multiple traumas. The patient could be in an unstable physiological state, already in the ICU, being taken up as a damage control procedure. So these will be all the ones which are sort of expected. On the other hand, there could be anaphylaxis to drugs, latex, blood products. There could be an embolic episode, and these will come into the spectrum of the sudden and unexpected deaths. Amongst the anesthetic causes, airway complications, we all know, lead to hypoxic-related brain injury, but they may not lead to death on the table. Respiratory causes, severe bronchospasm, laryngospasm, circulatory causes due to overdose, like Dr. Sunitha has said, overdose of drugs, overdose of propofol, and the effects of anesthetic agents on the circulation. Then there could be drug errors or drug toxicity like LAS. There could be drug errors due to miscalculation of doses, administration of wrong drugs, misinterpreting or misreading of the labels. There could be malignant hypothermia. There could be some equipment or monitoring failure which results in this event. Surgical causes could be a major blood loss, uncontrolled hemorrhage, some injuries, a cardiac arrest during a cardiac procedure, gas embolism, or during a neurosurgical procedure, a sudden gas embolism like in a sitting position, neurosurgical operation, tension pneumothorax, sepsis. So there are myriad of causes which may, so we as anesthesiologists should always be careful in every case, because we don't know what's going to happen to the individual patient on the operation table. So it has been actually found out that most intraoperative deaths, however, result from a combination of all these factors of the patient, underlying patient risk, the surgical stress of the surgery, and or superimposed anesthetic complications, which may have some superimposed human error or some judgment error on the part of the concerned doctors. So when a perioperative cardiac arrest occurs on the OT table, obviously the patient is on the OT table. If the patient is under general anesthesia, he will already be intubated. So immediate CPR is going to happen. If the patient is, even if the patient has not been intubated or the airway is not secured, the specialists are there, the anesthesiologists are there, right there. So airway is immediately managed. So in 90% cases, the patient will be revived or there will be a return of spontaneous circulation. And in that case, the patient, if the patient is revived, there's a return of spontaneous circulation, then the surgeon should be asked to do only a damage control surgery, bare minimum packing, just what has to be done so that the patient can be then subsequently shifted to the ICU for post-operative care, and the relatives can be, they can be prognosticated, and that gives them a little bit of time also to get adapted to this situation. But there will be the very rare scenario where the patient is not revived despite a prolonged CPR. There is no reviving of the heart, and when this, there are no guidelines as to how long this CPR should continue or when the CPR should stop. Now that will depend upon the underlying cause. Supposing the patient is bleeding and they just can't control the bleeding, the patient is completely exsanguinated, then there has to be a point when the entire team on the floor, the entire team, surgical team, anesthesia team, even the nursing staff, everybody agrees that now this is time to stop. So this should be a unanimous decision which is taken with the consent and the sort of, it should be a combined approval or agreement on the part of the entire team who is on the floor. And after this will lead to, so this will be what is classified as a death on the table. And this must be followed by certain immediate and delayed actions. Now, in the immediate actions, supposing you have declared the patient has died on the OT table, you have to debrief the entire theater team. All the equipments and drugs in the theater should be checked. You should be prepared to face the relatives, the police, and the media if it comes to that. And again, like we've been saying since morning, Dr. Anjali said and Dr. Sunitha also said, there must be an accurate record of the sequence of events, and this should include every detail because it is likely that this case file is going to be scrutinized and all the preoperative and the intraoperative records must be complete. If the death is unexpected and you are expecting some sort of a mob fury, then you must alert the hospital security. It is also very important to deal with the anesthesiologist, primary anesthesiologist, and the surgeon who is like to be very stressed and traumatized, and we have to deal with the patient. So in the next step, the immediate step to do is that you debrief the entire operating team, and the circulating team should have a debriefing session. And this is necessary in order to ensure unanimity and consistency on all the facts of what exactly happened in the OT on that day in this incident. There should be unanimity and some consistency on the likely cause of death. After that, whoever the team leader is on that particular day should delegate one person to ensure that the OT is not cleaned and touched, and all equipment should be left as such. One person should, of course, be delegated to complete and check the medical records, and the rest of the OT list should be suspended on that day. After this, the surgeon and the anesthesiologist should tactfully break the news to the family with compassion and sensitivity. And as per section 39 of the Code of Criminal Procedure, all deaths occurring in the due course of surgery and anesthesia on the table are treated as unnatural deaths and they need to be reported to the police. The OT should be untouched because pending police arrival, this, as I've already told you, this is counted as an unnatural death. And the OT now becomes akin to a crime scene. So one person, maybe the sister in charge, should delegate a person to ensure that nothing is manipulated or touched in the OT. All equipment should be left as such, and any equipment failure or any drug which is thought to be the causative agent should also be isolated for further investigations. Again, one cannot emphasize the importance of accurate drug keeping. All the sequence of events, this file, as we all discussed in the morning, this case can be taken up even after 2 years when the family decides to. So all the sequence of events may be either handwritten or electronically printed. Every detail of the routine followed for this particular patient, including the preoperative checkup, when it was done, who it was done by, whether informed risk was explained and taken as appropriate for that particular patient, what investigations were ordered, what is the type of surgery and anesthesia, which all personnel were involved, the exact timing of drugs and fluids that were used, what were the surgical procedures or interventions performed. All these details must be put in a proper manner in the file, and details of the resuscitation attempt, how much CPR, how many cycles, whether defibrillation was attempted, what drugs were given for CPR. All this must be documented because as we've spoken in the morning, the file should reflect that a standard of care was provided to this patient in all respects. After that, the family is called aside, you make them sit aside, you explain the details of what happened and maintain your compassion, sensitivity, and empathy, and inform them that this has happened, but the definitive cause of death can only be confirmed on post-mortem examination. So you must seek permission from the family for post-mortem and inform them of the legal obligation to perform a post-mortem and inform the police. So if they agree, you seek the police intimation. Even if they refuse, you have to call the police and you have to inform them that the power to waive off a post-mortem only lies with the police. The doctors do not have the power to waive off a post-mortem examination. And another very important thing, when you fill the death form, do not certify the cause of death until you are certain. Now, the consequences of this event, it has great consequences on surgeons and anesthetists. Again, this depends upon how unexpected the event was. It may result in a feeling of sadness, helplessness, and guilt. Maybe these people should not be working for another period of time until their stress levels have gone down. It has effects on the self-confidence, reputation, and career of surgeons and anesthetists. They may receive verbal and even by threats of physical harm from the relatives. They may be in mob fury. And then security, as I've already said, should be called for as the situation seems to demand. And medical legal litigation should be anticipated in all these cases. Now, coming to medical legal litigation, we've been talking about it since morning, but at this time, for whichever residents or whoever is the working doctors who are watching this, whenever we think about medical legal litigation, let us just briefly recapitulate the 4 pillars of medical ethics. Both medical ethics and medical, I think, litigation are, they are intertwined. So the 4 pillars of medical ethics are: number 1, autonomy. Patient autonomy means respect the patient's right to make their own decisions about their own body. And that means providing the patient a full informed consent about the procedure which is being done, all the possible risks and all the possible harms that can come to him during this procedure. So you need to have keep the patient fully informed. After all, it is his body that we are working on, and he must be fully informed. So we must respect patient autonomy. And of course, beneficence, we must act in the best interest of the patient. Non-maleficence, we must do no harm to our patients. And justice means we should give them the fair and equal treatment that they deserve. If we as doctors keep all this in mind, then I don't think we really need to worry so much, and we do not have to have a defensive attitude towards working. Now, how do they apply in this situation? See, if you go, even in an emergency case, patient is very sick, patient is in ICU. We are the invisible people, and the invisible person is very difficult to blame when there's a bad outcome. So even in every situation, the anesthesia, and the sicker the patient, the more important don't depend upon the surgeon, because we don't know what they say. You must go and meet the relatives yourself and explain to them what are the likely risks, what can happen. And then they will recognize you to be a carer of their patient. And then you have to establish some sort of rapport and some comfort, so they trust that you will do the best for their patient. As I've just said, respect the patient autonomy, take a properly informed consent of higher risk or high risk, and what are the risks involved and what are the likely post-operative course going to be. This must be explained to the patient in view of their autonomy, of respecting their autonomy. And then, as ma'am has said in the morning, we have to provide a duty of care, which is in line with patient justice, patient beneficence, and non-maleficence. So we want to give the patient the best treatment that he is due for. Every patient deserves a basic standard of care, which we should provide. We must ensure that none of our actions cause any harm, and whatever we do is only for the benefit of the patient. So in order to align with these 3 pillars, a standard of care should be provided in all cases. A thorough preoperative evaluation should be done. Whenever a junior anesthesiologist is confused, they should seek consultation from specialists or seniors as indicated. And then they have to have the knowledge and use their drugs and techniques judiciously as indicated by the patient's condition and his comorbidities. And of course, the only proof that you have done all this is by detailed record keeping. I'm emphasizing that repeatedly. Now, when a person has to prove medical negligence, there are 4 key elements that have to be established. Already ma'am has said this in the morning, I'm just repeating it here. Number 1, they are called the 4 Ds of medical negligence, which have to be proven or established. The first is duty, that there was a duty of care which existed. So obviously when you are operating on the patient, you are providing a duty. So there you are providing duty to that patient. Then there is a dereliction of duty, means that you fail to provide a reasonable standard of care. That dereliction of duty resulted in some damage to the patient. In this case, it resulted in death. And that death or that damage was directly attributable to the dereliction of duty. So these 4 key elements must be established. If these 4 key elements can be established, then the patient's relatives can file a complaint to the State Medical Council for disciplinary action against the doctors. They can pursue a case in the consumer court in order to obtain monetary compensation, and they can even file a criminal complaint against the doctor or the hospital if they want to. Now, there's another term that we should be a little familiar with. What is the burden of proof? Now, who's going to prove these 4 points? I said that there's a duty, dereliction of duty, there is damage, and there is a direct result of dereliction was the damage. So who is going to prove this? So the initial burden of proof lies on the party. In this case, it is the patient's family who have to prove these 4 points, that these 4 points were all established and there was medical negligence. However, so usually the burden of proof lies on the family, the plaintiff's family. However, if the death is a result of a situation where negligence is very obvious, then the principle of res ipsa loquitur applies. That means in Latin, the thing speaks for itself. And in that case, if it's a very obvious lapse on the part of the doctors, then the burden of proof shifts onto the doctors, and the doctors have to defend themselves in these four elements. So what is res ipsa loquitur? It means the thing speaks for itself. Now, for this doctrine to be applied in the case, three conditions have to be applied. Number one, it must be a very unusual event, which does not usually happen unless there is some negligence. Then that event must be in the exclusive control of the defendant. That means in this case, the doctors, that they only had exclusive control on this event, and the plaintiff or the patient did not have any contribution to this event. However, this cannot apply to all operating table deaths because the plaintiff does contribute. If the plaintiff is very sick, he's got underlying comorbidities, he's got extensive cardiovascular disease, he's come with hemorrhage, he's had a polytrauma, then so there's a lot of complex underlying causes in many patients. And so this doctrine does not apply to all operating table deaths. And it can be reserved for those specific situations where negligence is very, very obvious. Like wrong side surgery, you operate on the wrong side of the limb, you operate on the wrong side breast, and that is obviously a big mistake, or leaving surgical equipment inside the patient. In these type of situations, the burden of proof shifts onto the doctors, and they have to defend themselves in this situation. So now, how can we prevent these type of events from happening? As we've been saying since morning, we have to maintain a certain standard of care. So we have to know, all our residents and we ourselves have to be up to date with guidelines, recommendations, what is the interval of time between stopping clopid and giving spinal anesthesia. We have to have the knowledge. So we have to stay up to date. So there has to be a continuous professional development and stay up to date with latest advances in anesthesia protocols and safety protocols. There has to be an effective communication and teamwork between the entire surgical and anesthesia team so that mistakes do not happen. One should use checklists like the WHO surgical safety checklist to prevent accidents from happening or wrong side surgery and all that. Incident reporting, as I think some ma'am said in the morning, incident reporting is not done. So people don't report their problems, and that doesn't allow us to identify errors in the system and prevent these problems from again recurring and improving patient safety. So there must be incident reporting in all institutions. Of course, medication safety has to be done very carefully, proper medication management, dilution, dosing, and administration. Ideally, like Madam had said, tranexamic acid being given in place of bupivacaine in the spinal anesthesia. I have heard about such a case. That is because the ampules are so similar. So there should be color coding, and there should be very clear guidelines for ampules and drugs in our country. And of course, equipment failure can also lead to problems, and equipment maintenance, regular maintenance and testing of all anesthesia equipment can help prevent any malfunction, which can lead to patient morbidity and even mortality. So the important lessons to learn from these type of events is we have to know that anesthesia is the second most vulnerable branch for medical legal litigations after obstetrics and gynecology. This is what the DMA News Bulletin says. Always do a detailed pre-anesthetic checkup. Do not ignore the findings, whether it is in the emergency or it is in the elective scenario. Develop a rapport with the patient's family and take an informed consent so that they are also convinced that you are doing their welfare with their welfare at heart. In case of anticipated death, in case the patient condition starts deteriorating on the table, keep the relatives informed, keep telling them what's happening. In non-emergency cases, do not rush into surgery until the patient is 100% fit. Do not operate if the facilities are inadequate to handle the complications. Communicate the death of the patient to the relatives in a very sympathetic and sensitive manner, and handle the body in a very respectful manner. The important medical legal points that I would like to once again re-enumerate is: death on the table is classed as an unnatural death. Do not clean the OT. It should be preserved like a crime scene. Activate the hospital security if you feel threatened at any time. Always inform the police and insist on a post-mortem in case of death on the table, and you do not need the attendant's consent for this. A doctor should give the death certificate only if he is sure of the cause of death. Do not certify the cause of death if you are not certain. Complete all the relevant documentations, debrief the entire team, and ensure that all the notes are tallying. ensure the records are complete. In this sort of a situation, they are the only proof that you did your duty and provided the required standard of care before the event and even after the event. So provide good records of the CPR that you provided intraoperatively. Last but not the least, take care of your colleagues. The psychological impact of an OT death is very great. It can lead to, especially if it's an unexpected one or one in which maybe you have made an error, it can lead to feelings of failure, guilt, shame, and blame. It can lead to grief, sadness, anxiety, stress, denial, and it can even lead to professional burnout. So it is important that institutional directors should have support strategies for the people working for them. There should be critical incident stress management, which is usually done by professional companies to help diffuse the stress of the persons. It's a form of counseling. Before that, defusing can be done with the shorter, small groups in order to stabilize the team before a formal debriefing. The institutional director can provide one person to support this person through his difficult times. Peer support programs can be started for people who've had similar sort of experiences to share their feelings. And institutions should have some form of employee assistance programs, and there should be institutional policies to protect their employees in case of such incidents. So thank you. That is all I want to say now. Thank you. Be safe and keep your patients safe.
Thank you, ma'am, for such a very nice and elaborate, comprehensive talk on the topic. It's really very important. Although whenever we take up high-risk patients, we do take high-risk consent. But I just want to say one thing here, especially for juniors who are listening, that when we say, a lot of time people say, have you taken DOT consent? Have you? So DOT consent is not DOT consent. Nobody can consent for death on table. So we take high-risk consent with probability of death on table. So it should be labeled as high-risk consent only, high-risk consent with the risk of death on table. Yes, and in unanticipated problems, if something happens, then it's an unnatural death and it should be reported to the police. And as you said, ma'am, seniors and administrators, they should be involved. All institutes, they must make guidelines, SOPs for such events if it happens. Thank you, ma'am. Vineet, how can we see the questions?
Ma'am, can I add just one point? It's always whenever there is a medical negligence case comes up on death of table, it's always the duty of the doctor to prove that he was not negligent. In all other cases, it's the patient party who has to prove that doctors were negligent.
I think,
whereas in death on table, always it is the doctor who has to prove that he was not negligent.
Actually, ma'am, I researched this a lot. There is a very limited literature available on this. So I have read this. This res ispa liquidator does not apply to all OT deaths.
Yes.
I did check this literature. So unless initially the burden of proof lies on the plaintiff's family. Only if there is an obvious negligence, then the burden of proof shifts onto the doctor. But there is very limited literature. I saw some forensic books.
Generally, in such cases, court is always has soft thing for patient party. If there is a patient's death on table, then generally, doctor has to prove that due diligence was taken. Preventing death.
No, and of course, the doctors may be questioned, but the
may not be directly res interlocutor, but yes,
but the burden of proof lies on the plaintiff's family. If there is some shortcoming in your notes, or there is something to suggest, or like Dr. Sunitha gave, lack of monitoring, lack of adequate facilities, supposing there is no defibrillator available in the OT, then of course you are going to be very much liable for negligence in that case, because you have not provided standard of care. So yeah, we should not be compromising. If you look at that, in any case, we should not be compromising at all.
And if such a thing happens, then it's advisable that doctor should, take out literature and support oneself and keep a record of it, because after 2 years you may forget sequence of events. So you must keep the record, and you must take out articles from journals or from books to support your case.
And even if supposing something like an anaphylaxis or something occurs and the patient cannot be revived, then you can take out the literature to show that there is an incidence. It is a known complication.
Yeah.
It may be rare, but as long as there is reports in literature, then I think the doctor is safe, because as long as after the anaphylaxis occurred, he did the proper standard of care, that will only be reflected in the file, in the notes. If you took a complication occurred, which is perhaps a known complication, however rare, as long as you took measures after that to treat that complication, I think that we are safe.
Yeah.
To add to that, there are many drugs in anesthesia for which we can't give test dose. It's only first time we are going to give is in the theater, and we have to face the consequences, whatever happens. You can't give the test dose of muscle relaxant, or nothing can be done of that kind.
Sir, if I'm Dr. Vohra, sir,
Yes.
just one question, sir. Usually, NOTO has a list of recipients, prospective recipients, and they usually allocate organs according to the registration list number.
Yeah.
Is it possible? There was an article recently in Hindu that a lot of people are now saying that if a person is brain dead and wants to, the relatives, near relatives, they want to donate his organs, his or her organs to another relative who is in need of organ transplantation, who's a prospective recipient. But is it possible that the person donates directly to the relative, bypass the NOTO order?
List.
Is it?
I really don't think, I am in the NOTO advisory committee, but I don't think you can do that. I mean, they will, unless, I don't know. I mean, this is not there in any of their documentation. This much I can tell you. I've gone through their documentation, the new recommendations, new amendments and all that. Definitely.
And I think now they're trying to increase.
Like I say, there is room for everything. Like we had amendments for what you're saying. I'll probably make a note of that and probably find out from them. But as of today, it does not exist. As of today, it does not exist. Whether they can somehow convince the local authorization committee and get around that, but no, as otherwise you, first of all, another thing, you first have to be registered there. I mean, you have to be, let's say, if I have a need an organ, I have to be registered with this thing. These things very difficult. Somebody brain dead also, and you are registered also. It's a very difficult combination.
But if such a thing happens and you're part of that transplant team, are you the anesthetist involved is legally,
I don't think.
Okay, because
like
it's team,
today, as we are talking, it's not there. But this is something. Maybe you just remind me tomorrow, day after again, we'll put it through to NOTO and see, keep it in their agenda to consider. But there's something, these are the things that keep coming up. But no, you can't do that. You can't do that.
And Dr. Vijay, what first comes to your mind is, I mean, in the scenario Anjali described, foul play must be ruled out, that, I mean, there is always some suspicion. Agreed that the patient is a relative, but still, I mean, it doesn't sound, like as if you're doing justice, just because he's a relative and you jump the list. I mean, let's see. I mean, Dr. Vijay will,
I think law says that after death, organs become state's property. So
yeah, that's right.
So that's how they allocate. So,
can I put something else in this panel?
So please,
So standard of care, we're talking about standard of care all this time. So have we defined standard of care in your hospital, Sir Gangaram Hospital? Look, this is the standard of care for each individual in main operating theater or in main whatever neurosurgery or in this thing. Have we got it down in black and white?
So we have SOPs.
Have you got
SOPs.
it in what you call endoscopy suite?
SOPs.
And have you, I mean, what I'm saying is, are these what you call regularly visited. For instance, you get these are some SOPs. Then again, for the trainees, I mean, do you give them privileges? Look, like, she did mention someone new did something, but
DLT double, yeah.
double even
DLT.
true. But what I'm saying is, do we have a protocol or SOPs, or you have a way of giving privileges? And you say, tick, he's allowed to this endotracheal intubation, independent assist, central line, independent assist, double human, I mean, what I'm saying is, do we have those things in place?
No, sir.
Yeah.
No.
For residents, we normally we have SOPs for generally most of the situations and specialities. And for
residents,
So no,
for
there is
residents,
no
residents,
SOP
logbooks do
which
have
says
such
trainee should not be doing this. These are the things which trainee cannot do. There is no SOP for that.
but they have their logbooks in which they have and we have
their
instructions from
logbooks,
NB.
But
What
first
are
DLT you cannot do. That is, you should have done 100 a single lumen intubations to get a DLT. These things are not there.
I mean, these should be privileges, should be given by, let's say, you are in charge of whatever, thoracic surgery. You would be allowing privileges to this thing. So you should privilege somebody, and then only that person should be able to, be it a resident, be it me. I don't do it. So why should I be doing it in the first place?
So it is basically the responsibility of the consultant who is posted there. Even
Yes.
if the resident does something wrong or
It becomes
not able to
vicarious
conduct-
liability.
So the responsibility is basically the consultants
It's a vicarious liability.
who has so who
Okay.
has duty of care towards that patient, and our
Yes.
duty of care starts right when we take up the patient for anesthesia.
Yes.
And then the local guidelines, the institutional guidelines, these are also very important. Like what do you know, departmental guidelines.
Yeah.
So not
And
only
also
at
when we want to justify in the court, we should be aware of what are our rights, where all we can justify. Probably you can put it, he had done lot of single lumen intubations and still it has happened, and it can happen with anybody. If you don't have the documentation and justification, naturally we become susceptible.
Yeah. Another thing I wanted to say is, in our own institution, wherever we are, we should also have a certain things laid out. I mean, I know we follow it. We follow it to the hilt. I would say probably more than what we are supposed to do. But we must have something written in black and white.
Right?
These
And
are the
authorized by the management.
approved. So that tomorrow, if this thing, let's say for awareness, for your monitoring in your OT, you say this is the standard monitoring.
Yes.
Without the BIS. Let's say
I
without
don't
BIS.
have this. I have maintained a MAC of 0.8 to 1 with IV agents, and
So-
that is only it can be done.
Yeah.
And it should be authorized.
Yeah, that should be. That's what I'm saying.
Yes.
You make a protocol,
Yes.
get it, it will be approved by your whatever
Institution.
institution, and say this is, then they say, look, maybe it is not adequate, fine, that's okay. Nobody will be able to point finger at you.
But in court of law, your institutional policies or your institutional, that you have made, is it? Can you submit that? I think that doesn't carry
Ma'am,
much weight than
especially-
the ASA, than the guidelines by recognized, reputed societies.
No, ma'am.
That makes sense.
The compulsory monitoring as per ASA guideline does not include BIS or the depth of anesthesia equipment. When that is not available, but is not made compulsory, we have our own rules, which rules in our institute.
Yes.
Anjali, I agree with you. It
Like-
will be ideal if the ISA, which is the biggest
National body.
national body, if they make some sort of a guide, some sort of this thing, protocol, guideline, whatever you call it, that will be the best. Which
Yes, sir.
they don't do it.
Right, sir.
If they do it, that'll be ideal. But short of that, what else can you do? You come down to your institution,
Your
or you come down
institution,
to,
yes.
why not ISA Delhi branch? Let's make some
Yeah.
protocol for that. I
Yeah,
mean, why
that's
not?
why all these bodies, they should make guidelines for practical purposes to guide
Yeah.
clinicians. Yeah.
And that will support you in
Yes,
case
sir.
of you are
Right.
ever in trouble.
Mm,
And
yes.
also introspect. You see, support is one thing. It will make you introspect. Look,
Yeah.
are we doing, is this the right, or do we need to
Yeah.
improve the
Right,
standards a bit more?
Right, sir. Right, sir.
And we also should remember about the contributory negligence. That is patient being not compliant with any of the instructions which we have given. That will also reduce our risk.
Yeah, our yes.
Absolutely.
So,
I think if there's one question in the chat box. No questions from audience as of now.
Yeah,
So I
that's
think,
fine.
but I
Yeah.
think we had a really nice discussion, and
Ma'am,
thank you.
many of the people said they are not able to join. So if something can be done with that, about 5 to 6 messages have come to me. We are not able to log in and join.
Okay. So,
My top
Vineet,
And this
I-
is not only for this meeting, for quite a few meetings, this keeps coming.
I think we'll look into the
I
matter.
think Dr. Vineet will,
I'll look into that one.
Yo, hey, Vineet, what's
Vineet?
happening?
So all the three talks were very
People actually logging.
Anjali. Vineet,
Sorry.
please go ahead. Vineet.
Ma'am, I was just saying that logging with Clearnet, I'll have to talk to them. I'll apprise them of this problem. Last time
Okay.
also Dr. Sunitha ma'am has raised this issue. Yes, ma'am.
Because
Yes, sir.
the QR code which you have given, all of them tried with that to register. None of them were able to register. I am getting calls and messages continuously saying that ma'am, we are not able to register ourselves.
And ma'am, with this attendees link also I had shared.
You
Separate link for attendees.
no, for delegates you didn't share, na?
He shared a
Ma'am, I
link.
shared a separate link for delegates also, ma'am.
Yeah, the second one which you shared, that also I have shared with
Yes,
them. Yeah, with that also they were not able to.
I think Shreya is there. Maybe she wants to tell
Yes,
us.
sir. Yes, sir.
Learned
We
team.
will look into this, sir.
Okay. Thank
It
you.
should be made simpler so that if
Right,
the entry
right.
itself becomes difficult, we will not have audience at all.
Right, ma'am.
So I think with that we come to the any other remarks, Anjali?
No, ma'am, thank you, please.
So with that we come to the end of this very interesting session, and I think all my speakers and Dr. Anjali for the moderation. Thank you very much. Good night.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank
Thanks
you,
to
sir.
everyone.
Thank you, Dr. Sunitha. Thank you, Dr. Anju.
Thank
It was
you.
very nice.
Thank
Good
you,
night.
Dr. Anjali.
Good
Thank you,
night.
Dr. Bimla, for the opportunity. Thank you, ma'am.
Thank you, ma'am. Thank you, sir.
Thank you.
I wanted to congratulate you, Dr. Anju, but I couldn't meet you in person.
Thank you so much, ma'am. You gave me this opportunity. Thank you. It's always lovely to interact with you. Thank you so much. Thank you, ma'am.
Thank you and good night.
Yeah,
Thank
good
you.
night.
Thank you so much, everyone. Good night to all of you.
Good night, sir.
Thank
Bye.
Good night.
Thank you.